I'm a GP from Whangarei. I've been involved in healthcare homes in Northland since we got going. It's really exciting to come to a symposium and see so many people in this room. And of the people I've worked with inside the collaborative, by far, they're the most innovative, interesting, enjoyable meetings I go to by miles. I go to meetings where there's everyone in the room is positive. I come away buzzing basically every time I meet the leads or the governors. No one's got us here because we don't want to be here. So many times I go to meetings and I'm just dragged into them and I sit there and everyone's grumbling and they feel they've done something useful if they've said something. The other thing I think from a point of view, my practice has got 11,000 patients. We've been in a healthcare home journey now for a couple of years and we're still working at it. We've got lots to do. I ended up here though, not probably because I'm a GP, although I'm interested in change. I've ended up probably, if anything, my role in the Healthcare Homes Collaborative because I ended up as a consumer. 5 years ago I got really crook. I was off work for 16 months and while I was crook, Nick Chamberlain saw me sitting around, who's the CEO of Northland, sitting on my couch feeling sorry for myself and he said, can you do this work? See me get healthcare homes running up in Northland. So that's probably one of the bigger reasons I'm here. Being a consumer opens your eyes to how crap the system is we provide people. I had no access to a care coordinator. I had no access to shared care planning, patient portals. I couldn't ring my practice. It sharpens your focus a little bit. I don't recommend it. But in fact, being on the other side of the fence, what we do, I don't think we could call ourselves a service industry at times. That might be a little bit challenging. And my bit of this talk today is really just about what we can do to keep people sitting at home where they don't actually have to come in when they don't need to. And I think there's a lot of times where patients are unnecessarily asked to come to the practice because it suits us. And I think that some of the things that we could do better in terms of clinical triage and also patient portals are things I'm trying to champion. One thing about the collaborative is that we're pretty good at sharing things. We're good at borrowing things, and dare I say we're pretty good at stealing things off each other at times. So the next little thing I'm going to show you has actually been stolen off Martin Hefford. I see Martin's arrived, I have to apologise, which I thought was very amusing, but it's actually a grain of truth. Probably the most difficult people to change are my colleagues, my GP colleagues, who by nature are quite defensive. We don't want to drop the ball. We ask a lot of what-if questions and at times find things that are where it could go wrong, whether it could go right. And so to a degree, this next little video, which I've stolen from Martin, tells you what it's like dealing with GPs. If we'll move forward.
This man right here is my great-grandfather. He was the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know.
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
EDS.
So although there's an element of humour and you can't have any presentation without internet cats, the problems that I've had most often in my practices are actually trying to persuade my GP colleagues that this is all going to be all right. Interestingly, in my own practice, once we learnt some lean processes, my practice manager, the administrative staff and the nursing staff just jumped at it. We flattened off, I guess, the decision making, and they've done all sorts of amazing things that have made the practice much more lean and efficient and dragged some of their GP colleagues along with them. And I think just before I start talking about portals and triage, I think some of the stuff that we're trying to do in our practices just end up being much more person-centred, to actually see that we're not trying to provide services around us. I mean, at the moment we're quite self-serving to a degree. I think the real power of primary care is that continuous relationship you can develop with people over time. I think GPs are, if you had a specialty, we're continuity and relationship specialists. We're not all that good at the moment coordinating our services, both with all the NGOs and other providers and secondary services. So I think we can champion this. I think we can be the leaders. Rather than waiting for people to do this for us, we can be the place that actually says this is important and gets on with it. And wherever possible, to save people having to navigate the system, we can become the place where comprehensive care is delivered. So it's an ethos. This isn't a tick box exercise. This is more to do with how we think about things. And for my own practice, we weren't very good at problem solving. Problem solving skills are really lean in primary care. We get very little training in how to deal with the problems inside our practices. We learned how to do this. Healthcare homes taught us that there's ways of resolving problems. And once we learnt them, away we went. Many of my colleagues will go to conferences and all we ever hear about is clinical things. We never hear about appointment books or business practice or lean or any of the stuff that could make a real difference to how we're able to deliver care. We got the joy this year. I went to 2 NZMA conferences to speak. I spoke to practice managers. I was speaking to a sold audience anyway. Meanwhile, GPs were next door learning about heart failure and COPD. I mean, our patients expect us to be clinically competent, but we also have sustainable practices that do them better than we're currently doing. And we've got choices. We can make choices. We're not trying to be radically different. We're just trying to do things better, I think. And when I walk through my door every day, I have some responsibility for what goes on. I can't blame the PHO or the DHB or the Ministry of Health if things aren't going quite well as they should. It's actually my responsibility. I've got to actually stand up and go, could we do this any better? I'm going to mention the patient test a bit later when I start talking about portals. It's something, again, I stole it off Helen Parker, who talks about whether what we do can actually be defensible to our patients. So when I bring it up with patient portals, you'll see how this actually works. But if you were a room full of my patients and I actually told you what I did and how we did it, would I actually be able to defend that? Is it reasonable? And quite often it won't be. Quite often it'll be, I made you drive in, you didn't really need to come in, but it suited me, you got an appointment and it was empty, so there you are. So we'd often end up probably likely apologising at times for what we get up to. So I will talk about that. And during the day, I think it's worth keeping in the back of your mind that the things we do, we can change. We are responsible for change. And if we do change them and they're better for patients, then you're probably closer to passing the test. That's what my practice used to look like 2 years ago, honestly. I used to stand on the back door with one of my business partners, and he and I just used to call it a train wreck. We'd get between the back door and our rooms and have been accosted by 4 or 5 people needing things done, trying to fit extra patients, and got stuff that just wasn't sorted. This particular partner is probably New Zealand's grumpiest GP, if not second grumpiest. He said to me the other day, this healthcare home stuff, before it started, this place was horrendous. It was just a complete train wreck. It was a disaster. He says, now I'm just really, really busy, but it's manageable busy. So that was a pat on the back. It was an okay from probably the grumpiest person I've ever come across. So how does this model look, in terms of from patients' end? So I'm going to talk a little bit about the stuff there and when I'm unwell, but the elements can be looked at from a patient view, or they can be looked at from a model you guys would have all seen. I'm going to talk now just about this unplanned and urgent care bit, and starting off with what we do with triage. It's probably been the biggest thing in my own practice that's saved our sanity. We're a couple of full-time equivalents short at the moment, and it's actually kept us afloat. Up north in Kaitaia, you would have seen on TV in the Sunday show, they've got a bit of a disaster area with workforce at the moment, and they are only surviving by doing triage. They've increased this book on the day appointments and doing much more triage, and it's keeping them afloat. Before I do that though, and you guys have probably seen this and probably going, well, this is bloody obvious, but going back to my GP colleagues who are at conferences learning about heart failure, they hardly ever done the maths about why the hell would you want to triage people away? Why would you not want them to all come in and pay your copay? That seems ludicrous. And honestly, when I present this, particularly when they've done their EOI and wondering about starting the process, I show them something very simple. If a patient doesn't come in at all, we get the capitation for them, we bank it, Don't get any copay, but that's my profit margin for no visits for the year. As you go up, it costs about $75 every 15 minutes to provide general practice services. There'll be a copay, and VLCA it's low and access is a little higher. But at some point as you follow that line across, your revenue and cost line cross. And basically, if you want to be more sustainable, you're either going to have to reduce your face-to-face consultations, you're going to have to reduce your cost per consult, which you can't do because there's prices, or I guess put the fees up, which is probably something that we can't do easily either. That's my own practice. We've got a crossover point at 3.6 visits per year in utilisation. It's counterintuitive, but the fewer patients I see, the more money I make. Why that's an important concept is our population is ageing, it's getting more unwell, it's more likely they're going to be utilising higher, and that's actually the heat map for my own practice, and you can see the over 60-year-olds are utilising way past that 3.6. Some can be sorted with triage, some can be sorted with better routine care, some can definitely be sorted with proactive plan care, but it's a driver actually to try and move this in a way that actually reduces utilisation if it's the right thing to be doing. And if we don't, then our profits drop, and then we become unsustainable, then we close. I think a lot of the model, we're often talking about patient experience, and no doubt patient experience is important. But when I was talking to my colleague on the back doorstep, his own care team wellbeing wasn't good. My practice was frantic, it was really unpleasant at times, and I think that with anything we do, we should be looking at how this impacts on us. I know for a fact that our huddles every day and our triaging and the way our practice now flows is making it a much more enjoyable place to work. We just feel so much better about coming to work. And some of that, I think, was outlined in a little bit of research done in Northland where some guys from Auckland University talked to 21 people within the first 4 of our practices to see how they were going with healthcare homes. And the things that we thought they might not like and the things they actually recognised as being useful were some of the new things. So at the top there, the administrative staff in that green block thought that doing triage was awesome. And I'll explain why when you start looking at how we've leaned the process. Surprisingly, GPs dumped straight into triage. Most of them thought that was one of the best things they were actually doing, and portals they also liked. So I'm just going to get on to phone assessment and triage, and I think the first thing we should start at is just dispelling the myth that somehow we're a tick box exercise of standards that you have to complete and come from one end to the other. Very much our standards are aspirational. There's a whole lot of elements we're trying to do, and we're going for from starting point of 0 or 1, trying to get across to what good looks like. So with triage, you start, don't do it at all, right through to what we think is the gold standard, where you do it all day with a prescribing and diagnostic clinician wherever possible at peak volume, so they can actually organise everything the patient needs there, and wherever possible also providing continuity. So you could go past that, you could go past number 4 and come into number 5 where you've absolutely perfectly matched demand and supply and demand. So there's an endless way you can improve. I'm sure that every day we're doing things reasonably well but not perfectly. We're also aiming, I guess, looking at triage is obvious, we're trying to value patients' time, particularly in Northland where we've got tyranny of geography, distance and crappy cars, that if someone doesn't have to come in, then that's a really big bonus for them. It's helping us handle acute demand, and certainly it has recently in our practice. Provides another option for care, frees up time for proactive and planned care, improves our business efficiency, as I've mentioned, and gives people a choice, something they didn't used to be able to do. And lean call handling has been the real goal, the gold in what we've managed to do at my practice. And why our call handlers like it so much, they don't now have to negotiate for making appointments. It used to be dreadful. We'd have up to 6 or 7 doctors working. They'd have 6 or 7 books open. People would be ringing. They're trying to find them slots for that day. They weren't clinically trained to do it. They'd pass them to nurses who'd ring people back. It was just a wreck. Now they just go, yes, we have got appointments today. What's the best phone number to give you a call back? Someone will call you in half an hour. Can you give me a heads up what's going on? Down goes the phone. They're on to the next call. We're the same. We call people back and go, yes, we've got appointments today. Just giving you a call to find out what's going on, work out what the best plan of action is. So from both ends, it's become so much simpler to sort things out and taken a great sort of stress out of our day. The other thing we were able to do is, this is from Te Araha practice, I've stolen this as well, I've got a habit of this. It's just their data from days of the week, what the busiest days are, and also busiest months. And from that sort of thing, they can plan a little bit. They get a temperature of their practice, how busy it is, how many slots they need to free up every day, how they're going to manage leave, or who needs to be available to take phone calls on any month or day of the week. And they can work out where best to apply doctors and their nurses in terms of getting the best bang for bucks in terms of resolution rates. Out of all this, out of all that triage, you do get some data. I'm not going to dwell on this, but it gives you an idea what resolution rates are. This is my own practice. At one point, we were running at about a 40% resolution rate for phone calls. On any given Monday morning, probably between 7:30 and 8:30, we answer 25 calls. Probably free up a whole doctor's morning by doing that. What we have noticed in certification as we look around the country, that there isn't actually a correct resolution rate. It's a clinical judgment, and I'm going to show you what happens in my own practice in that regard. We can look at the number of calls that people are taking. That's again the resolution rate across the a 6-month period. It varies from time to time. Sometimes it's 40, sometimes it's 30. There isn't again a correct amount. It's just what people ring it up about. To give you a slight idea of some of my frustrations, I recently had a conversation with someone who was saying that my practice has slipped backwards because we'd run from a 35% resolution rate to a 31. And I said, what? And he said, well, you've gone down by 4%, you're resolving 4% less people. And I was going, there's a natural variation around an average, isn't there? And they were a contractor and they didn't quite understand what we were doing, but there's a frustration when you're talking to people who don't quite get what we're trying to do from a clinical sense. Again, that's the length of time, 2 minutes 44 for a call. We're not actually consulting, we're just actually trying to sort things out quickly. And again, that's the slide that shows just across my practice of variation and resolution. So one doc's running at 17%, one's at 55%. There's a level of comfort, or whether you know the patient or whether you feel you want to do that. Dare I say the 17% person hasn't bought into healthcare homes. Their view is that I don't care if there's an appointment, I'm going to book them in, put the phone down, and I don't think we're going to win that apart from maybe taking them off. So even within a practice, you're going to find people that don't want to do this at times. This slide here probably is the thing that changes many of my colleagues' mind though about this, is that blue dot's a practice in central or northern Whangarei. It's got a high needs population. I think there's 70% high needs, about 70% Māori population. Those red dots indicate where people have had their triage call resolved over the phone, they haven't had to drive in. We're looking at drives of up to an hour and 20 minutes one way. I say down dodgy roads, no petrol, no reason to come. And if you don't need to come, why are you asking people to come? So, we're doing reasonably well, I think, in triage. We've got a triage form, you would have seen it, and there's pretty much no training. You say, how you train someone to show them how to open the form. The staff and patients love it. People are ringing and say, can someone give me a triage call this morning? And it's one of the things they talk about with great enthusiasm. We don't have to add data in. It's not actually a data exercise, but there's a lot of information I've just shown you comes out of it. And reports are available to the practices as well. At this point, I might get a bit grumpy. I'm onto patient portals. Strictly speaking, patient portals are probably not urgent unplanned care. Although I know Jeff Lowe's practice has got 90% of patients on a patient portal, and they do use it for doing same-day urgent unplanned care triaging, and they've got a process in place. And I think the future is probably likely that more and more times we'll be able to triage people away in a way that actually uses electronic formats. It doesn't require us to ring people, so it can be used that way. Why I want to talk about it is that I've got a big interest in this. I got dragged in by the Ministry of Health way back in 2014 when portals arrived, because we put one straight in as soon as they're available in my practice. I was an e-ambassador for the Ministry of Health. It sounds a bit weird. No kidding, the very first poster the Ministry of Health put out when they realised doctors weren't taking it up said, "You can incise a perianal haematoma. Why are you scared of portals?" My God, No shit. That's just crazy. That's the level of resistance immediately. This is an indicator, I think, of some of the worries my own colleagues have with innovation. So patient portals might sit there inside your model of care. I mean, it sits there as a functional patient portal. But if you think actually what it does for your practice, it does a whole bunch of things inside that model. It does a whole lot of the day-to-day activities that you're otherwise wasting time doing. And so, so why use them? I mean, I'd say it's obvious, aids your workflow, it encourages patients to self-manage, it provides patients with another way of doing things. And for patients' ends, it does a whole lot of stuff. You can look at your records, you can request repeats, you can get message of practice, you can get appointment times, and look at things like immunisation rates. The bit that it gets me grumpy is this. The ministry on people who go, oh, look at that graph, look at that line, just going up bit by bit by bit. Isn't that good? Wow. If that was any other industry where someone introduced a thing that had such a profound effect on your patient's well-being, their activity, their ability to run your practice more efficiently, there'd be a graph that would be zero. The first bank, the first hotel, the first airline company would introduce it. Within 6 months, it would go from 0 to 100%. That line would just go straight up and straight across. That's the service industry. If you've got servicing people and you want a better run at it, you would actually provide it. What's going on? This is a complete and utter shambles, in my view. We've now got 737 practices in New Zealand offering the portal, so 3 in 10 don't. Out of those 105 practices offer open notes. Joe had done a bit of an exercise. I'm just interested. So in this room, how many people in this room have got a patient portal at the moment? So who doesn't have one? Not many. That's good to see. Just a matter of interest then, that you've got it, obviously that's really good news for you guys. How many people when they went in were systematically offered the portal by their practice, actually didn't ask for it, but actually got offered it by someone's... Could you put your hands up? Wow. So that's different. So the rest of you have gone and asked for it. That in itself is, a telling. How many people have got open notes? So of those that have got a portal, how many haven't got open notes at the moment? Yeah, lots. So, Helen's patient test. Helen's patient test would say if you or all the people in this room were patients, you'd go, the technology exists, allow you to get in and out of your records. It's called a patient portal. How many of you don't have it and don't have a practice that offer it? Well, 3 out of 10 in New Zealand don't offer it after 5 or 6 years of being available. There's no reason why they wouldn't, so you'd fail the test. The other thing, the next question is, well, you've got it, but how many people in this room actually were systematically offered it? A whole lot weren't. They had to actually go and make an effort to get it. It wasn't something that was gone, here we go, I'm a service industry, I'm a business that's trying to look after your best interests. Here it is. And I think with our healthcare homes, we're really working at making that just standard practice. Jeff's got up to 90%. How long did that take you, Jeff? 6 months? A couple of years. But you worked at it solidly. You can get up to 90%. One of our practices in Whangarei is at 75%. We're at 42, I think, my practice and working at it. So you might go, I'm systematically doing it. I'm a healthcare home and doing my best. And then you'd go, well, you open your notes to the patients. And you go, well, what would I do that for? Isn't that dangerous? Isn't that something that actually might have them reading my notes and I'll get into trouble? So mass, 70% of people in 77% of practices offer it to 20, on average 20% of people. That takes it down to 14% of New Zealanders. 1 in 8 have open notes. We're down to 2% of New Zealanders 6 years into portals have got open notes. And that's frankly not good enough in my view. And just talking about open notes, if you want to ever get your practices or persuade them why they'd have a portal, I'm not talking about the business sense, but just having one full stop. There's a YouTube video by a guy called Tom Del Banco. It's called Opening the Black Box. It's about 28 or 30 minutes long. If you watch it, you won't have practices just putting a portal in. They will open their notes. They'll actually open them having watched it once. If they don't, they need to find another job. And why is that this study they did in the US, they had 13,000 patients, and they actually asked them after they'd read their notes, been involved with open notes, what had happened to them. If that was any other medical intervention, you'd be unethical not to provide it. And you can clearly see those numbers are staggering. That is an incredibly powerful and useful thing for you to be doing. So I've got a 2-minute warning, so I can shut up whenever I like. I just want to say, I think, did John McCaskill-Smith come in? No? Hey, John. I just want to say, actually, thank you. Well, here we are in the home of Health Care Homes in Hamilton, and I think, personally, what Pinnacle Ventures has done for Northern in terms of supporting us through this journey, your generosity, your passion, your, dare I say, bloody mindedness at times, has dragged us all along, and I think we probably wouldn't have a room full of people without what you guys have done. You're keeping us honest as best you can. I'm really excited that we are all here. I think from where we started and considering how far we've gone, you're a room full of people who are saying we want to take some responsibility. And I say, from a consumer lens, and I go around the place, I've actually got formal roles. I talk about the health care homes model, I talk about portals, I talk about shared care, advanced care planning. And if we do this, we're doing the people we serve a great deal of good. So I hope you have a good day. I hope you walk away from here enthusiastic and sparked up. And so thank you very much.
G'day.